As with many things, children are not small adults when it comes to bipolar disorder. The way that bipolar symptoms are expressed in children and adolescents can look wildly different than it does in adults. While we use the same approach when we're diagnosing adults and children and adolescents with bipolar disorder, meaning that we're always looking for a clustering of symptoms that represent either a depressive episode or a manic or hypomanic episode, and that these symptoms need to travel together and create impairment, the ways that these episodes are experienced and the specific characteristics of these episodes differ between older and younger populations. The first difference is the nature of depressive episodes. While adults typically experience depressive episodes characterized by sadness, tearfulness, and feeling very down, children and adolescents are much more likely to experience irritability when they are depressed. Periods of depressive irritability might be experienced alongside periods of feeling very low or tearful, or kids might exclusively experience irritability when depressed and experience few, if any, periods of sad, tearful mood. Although this isn't a specific part of the diagnostic criteria, we tend to see a more withdrawn, isolating irritability when it's part of a depressive episode. With manic or hypomanic episodes, we're again more likely to see agitation or irritability rather than an expansive or elated mood. Additionally, children and adolescents often experience brief explosive periods of emotional and behavioral dysregulation, which we often call rages, that can include aggression towards themselves, towards others, or destruction of property. And finally, the ways that symptoms are expressed are largely age-dependent. For example, poor decision-making in an 11-year-old may include cutting off all of her stuffed animal's ears, but poor decision-making in a 17-year-old might include deciding to go for a 6-mile run at 2 in the morning. And finally, the symptom course of early onset bipolar disorder is really quite different from what we see with adults. Episodes are typically much shorter, maybe lasting only a few days rather than a few weeks or months, with increased frequency of mixed episodes, which means an experience of both depressed and elevated symptoms at the same time. Children and adolescents also experience more time with subsyndromal symptoms. In other words, less time when they're totally symptom-free. And again, the ways that symptoms are expressed varies greatly across development. Hyperactivity may look quite different in an 8-year-old versus a 12-year-old versus a 17-year-old. We can see additional differences if we take a closer look at those experiencing bipolar disorder before the onset of puberty compared to those experiencing bipolar symptoms throughout adolescence. In our youngest patients, we see particularly rapid mood shifts, with depressive, elevated, or mixed episodes potentially lasting even less than a day. Children tend to experience an especially high rate of mixed mood symptoms, which again is the simultaneous experience of both depressed and elevated symptoms. Children with bipolar disorder frequently experience behavioral problems, whether as a direct result of their mood symptoms or as part of a co-occurring behavioral diagnosis. Although co-occurring anxiety disorders are quite common for younger patients with bipolar disorder, children are especially likely to experience separation anxiety. And finally, prior to adolescence, any psychotic symptoms are most likely to be auditory or visual hallucinations. For adolescents, we still see a pattern of episodes that's more rapidly shifting than what we see in adults, but adolescent episodes do tend to be a bit more clearly defined and longer lasting than what we see with young children. We see an increased experience of suicidality in adolescents, as well as increased risk for using substances. Again, it's very common for youth with bipolar disorder to have a co-occurring anxiety disorder. In adolescents, we see an especially high rate of panic disorder. And finally, in adolescents who experience psychotic symptoms as part of their bipolar disorder, we see the emergence of delusions. To better understand the experiences of bipolar disorder across the lifespan, we might try looking at this a little differently. This is an example of what a mood chart might look like over 6 months for an adult with bipolar disorder. What we see mapped out is an extended period of depression followed by elevated experiences that last several weeks. For an adolescent patient, We might expect to see 4 to 5 episodes during that same 6-month period, which might look something like this. And when we look at what that same 6-month period might look like for a child with bipolar disorder, we're likely to see especially rapid mood cycling and few, if any, periods of stable, symptom-free mood. One of the most challenging aspects of childhood bipolar disorder is just how rapidly and unpredictably mood can change. Parents talk about not knowing which mood their child is going to wake up with in the morning. It's understandable why this can be an overwhelming experience for both patients and their families. Thankfully, we're starting to get some solid ideas about what behavioral approaches might help these younger patients. These psychotherapies listed here were initially developed for use with adult populations and have since been modified and validated for use with younger patients with early onset bipolar disorder. Family-focused therapy for bipolar disorder is a psychoeducational treatment where families learn to identify and respond as early as possible to the symptoms of bipolar disorder. Families also learn a series of communication skills and problem-solving skills to help keep the family environment as low-key as possible, even in the midst of the stress that can go along with early onset bipolar symptoms. One of the most useful skills that is emphasized in FFT is the daily habit of mood charting. In order to respond to emerging symptoms as early as possible, families first need to develop an expertise in recognizing initial signals that mood is worsening. We encourage patients to develop their own personalized mood charts and then reflect on and track their experiences each day. This has the power to dramatically improve response times to emerging mood episodes, which is a crucial component of effective illness management. For more information, please check out our mood charting videos on the CoBE website. Interpersonal social rhythm therapy, or IPSRT, is another evidence-based approach that aims to stabilize patients' mood by stabilizing their daily rhythms. When routines are less consistent and predictable, bipolar patients experience more difficulty with regulation of their mood symptoms. Everyone experiences this to some extent. For example, this slide illustrates some of the aspects of the roughly 24-hour cycle of our circadian clock. Things like body temperature, hunger, alertness, energy levels, or release of certain hormones follow a roughly consistent, fairly predictable pattern for most people from one day to the next. We experience difficulties when there are even minor changes to this rhythm, for example, when changing the clocks for daylight savings time. Patients with bipolar disorder are especially sensitive to changes in routine, and similarly, may be especially responsive to improved consistency in their daily rhythm. There are many aspects of one's daily routine that can be made more predictable. For example, when someone chooses to exercise, when they eat meals, when they spend time with others or engage in their work for the day. Although most people really seem to get the most benefit from prioritizing the consistency of their sleep schedule. Research shows that the consistency of a patient's sleep schedule is much more important than the specifics of when they're actually sleeping. Meaning, for most individuals with bipolar disorder, a job working a day shift would be ideal, but that in the absence of a day job, a consistent evening shift is preferable to a job with alternating or unpredictable day and evening shifts. Regulating sleep can be an especially challenging task for children and adolescents who may want to stay up late and sleep in on the weekends. For most people with early onset bipolar disorder, reducing the scope of that shift between weekday and weekend sleep is effort well spent, as it can have a significant impact on mood stability. Accumulating evidence also suggests the likely benefit of using these protocols in working with children and adolescents with bipolar disorder. Cognitive behavioral therapy, or CBT, highlights the important relationships between one's thoughts, behaviors, and feelings. Dialectical behavioral therapy emphasizes the importance of mindfulness, interpersonal skills, and emotional regulation. And finally, acceptance and commitment therapy, or ACT, helps the patient to develop a more effective, healthier relationship with their thoughts and prioritize value-driven behavior. To summarize, We know that bipolar disorder presents differently across the lifespan. Children and adolescents with bipolar disorder experience symptoms differently than adults with bipolar disorder. Youth tend to experience more irritability and agitation and have briefer, more quickly shifting episodes and fewer periods of being symptom-free as compared to adults. Despite these differences, many treatment approaches that are helpful with adults can also be helpful with younger patients. Specifically, mood charting and management of social rhythms can be effective strategies for early onset bipolar disorder.